Hello and welcome to this webinar. My name's Fiona Wisniaki and I'm the Same Day Emergency Care co-lead for the Hospitals Programme for NHS in EI. And I'm here to welcome you to Dr. Jordan Bowen, who's a consultant physician and geriatrician and the clinical lead for acute medicine and ambulatory care at Oxford University Hospital. Thank you for joining me today, Jordan.
Thank you for inviting me.
That's great. So a key component of getting the urgent emergency care patient to the right place first time is the clinical conversation. And I know that you've had a lot of experience with this over the last few years. So what do you think the key components are to this?
Well, thank you so much, and I totally agree. So we've been exploring this clinical conversation to guide the direction of patients to our same-day emergency care unit for the last 3 years or so, really opening up that clinical conversation to any referring clinician outside of the hospital. And so that tells us it doesn't have to be anybody of a particular grade, but what's really important is the credibility of, one, the referring clinician, so someone who's in front of the patient or at least knows enough about the patient to make the referral. 2 is the credibility of the receiving clinician. And 3 is the ownership of that decision. And so the way it works best, I have found, is that when the referring clinician, let's say a paramedic colleague, has made the good assessment, is able to contact me with ease, so it's a frictionless contact. I'm taking a call, and it is within my interests to be able to determine the right place for a patient to arrive. And together we create this kind of symbiotic decision-making complex where we both have skin in the game, and we are deciding really what, given the patient's context, where is best in the system for a patient to arrive for the next stage of definitive management. So that's the first thing, is credibility. 2 is that sense of shared decision making. 3 is going to be, I'd say, a continuity. So I know that if I agree that a patient is going to come to us in our same-day emergency unit, that I now pick up on the next stage of assessment. And so the conversation has already led into some of the information gathering. And in fact, I've got some time to gather and enrich the pool of information that the system has about a patient. So that might be from trawling through our online systems for clinic letters or preempting a scan. So that lead-in time before the patient arrives is hugely valuable, and having the ability to participate in that is another important responsibility, or rather attribute of a successful conversation.
So thanks. So really you're advocating it doesn't have to be a consultant that has to be manning that phone. If it's the nurse on the unit or an ACP, advanced care practitioner, and they've got access to the system, is there any other knowledge that they need to be having?
Well, I think it's a great point. So I absolutely agree. It doesn't have to be a consultant, and the parts of knowledge that are necessary is clearly some reasonably good clinical knowledge, and the ability to be familiar with independent decision making. The process or network literacy is really important, and in fact is one of the most important components, because a lot of the time we are deciding where the next step for a patient ought to be, and sometimes that's not our unit today, and sometimes that might be a different same-day emergency unit in a different part of the county. It might be a different hot clinic. So that network literacy is hugely important. And then third, it is, I'd call it again, when we're talking about literacy, it's risk literacy, and it's an understanding of what are the parameters of risk that are guiding our decisions, and that comes more easily to a senior clinician, but I think with a culture of practice can also be shared with other non-consultant colleagues, and we started doing that with registrars in understanding what are the risk parameters for decision making, particularly when deciding that a patient ought not come to hospital right now, but one needs to manage the risks of an alternative.
Thank you very much. That's so clear. And really exciting times about, are ahead, I hope, so that we really can try and get the patient to lots of other entities. So if you were to teach a clinician in ESTEC, you've just mentioned your registrar or a nurse, to receive those calls from 111, paramedics, a GP, or the emergency department, how would you do that? Would you use any tools at all, just as a starting point for really training that clinical conversation, the clinical leadership, the ownership, but to ensure that the referral process is a safe process?
Yeah, so great question. And I think we're still evolving the education that's necessary, because this doesn't come easily to most clinicians who've gone through a sort of conventional training program. What is hardest is learning how to make a decision about a patient that isn't necessarily in front of you, where uncertainty is integral to the decision. And so for many people's default is, I can't make that decision, so I'm going to see the patient, or I'm going to choose not to make a decision. And we want somewhere in between. So the key things that we try to teach is, one is the necessary framing, which is that that uncertainty is normal, and two people speaking, one of whom is the referrer in front of the patient, and two is the referral receiver who is within the receiving environment. They're the two experts who are best placed to make a decision, and best placed to navigate the uncertainty. So one is the framing of that. Two is it's a co-produced decision. So that means both sides have a responsibility. We're not trying to be a wall. We're not trying to bat away. We're not trying to prevent patients from accessing services because it suits us. So so we are part of that, and we own some of that responsibility of making a good decision. Three is exploring where the referring clinician's concerns are. And I tend to liken this to taking a history from a patient. So we all know some patients are very clear in the story that they're giving us, and other patients really are not. Some people call them poor historians. We all know that the historian is a history taker, right? So the key thing to say is that when we are taking referral is to be adaptable to the kind of person that's making referral. It might be a student paramedic, it might be a senior GP, it might be anybody in between with a different background. And so it is the responsibility of the referral receiver to try to sense where they are and try to facilitate that sharing of information without judgment. And necessarily you adjust a risk threshold according to the information one's getting. Facilitating the referral maker, I think, is another big part of the attitude and behavior that we try to instill in our call handlers. Then comes the more kind of bread and butter clinical information that's exchanged, and you expect a certain standard of information, but and that can happen at a diagnosis level. For example, what are the key questions to ask around chest pain or PE or infection? But alongside that is how worried are we? How worried is the clinician in front of the patient? And we know paramedics have a whole spectrum of severity of illness that they've witnessed. So I am often comforted by a paramedic who is not concerned about the acuity of a patient, but rather has made a gestalt judgment that something is necessary, but not immediate resuscitation, and it's not an emergency. So sensing that level of concern is hugely important, and we ask that question: how worried are you about the patient right now? The next aspect in the training, and importantly, none of this is anchored to to a particular kind of clinician. So it doesn't have to be a consultant. This can be applied by any level of clinician. So the next thing is determining what next steps are necessary to address the issue at hand. Does a patient need to come and be seen now? Is there an alternative to hospital conveyance? Is there GP, community-based services, or in fact, no action necessary now? And exploring those options together rather than being didactic, I think, is another part of the decision making. And then finally is some of the parameters around the process of coming to same-day emergency. So what people often don't ask when taking referrals is, how is a patient going to arrive? Can they come under their own steam? Or do they need to be conveyed by the emergency services? Can the emergency services be released to attend another case? And I think asking that question and agreeing that that the risk is low enough for a patient to convey themselves, I think is an important question to address in the conversation. Secondly is, how is a patient going to get home? Can you ask the patient whether or not they've got their own transport to get back home? Third is setting expectations. So that means, please let the patient know that we're going to see them today. It's likely to be a long day, but we expect them to get home this afternoon or this evening. So that sets expectations from the beginning, which helps the process all along. All those things can be taught through traditional means, but we find that actually reflection on cases, some simulated scenarios, and a shared culture of practice is the best way of educating colleagues of any level in delivering that kind of phone conversation.
Thank you very much, Jordan. And of course, all of this will ensure that the patient has a great satisfaction, for that whole experience, from the referral being made to the time that the patient is discharged from the unit. So what we're going to do now is have a look at how it's done. So how is the clinical conversation simulated, acted out, with the referral being made from the paramedic to Jordan.
Hello, ECIST Assessment Unit, Dr. Bowen speaking.
Hi, good morning, Dr. Bowen. My name's Steve. I'm a paramedic at South Central Ambulance Service. Just wondering if we can have a quick chat about a patient that we're currently attending.
Yeah, sure, of course. Tell me.
So the NHS number for the patient is 2291 374 2870, and that should be a 374 2870.
2870, yeah.
And that should be a John Bishop with a date of birth of the 1st of the 4th, 1980.
John Bishop. And just repeat that date of birth again for me.
The 1st of the 4th, 1980.
First of the 4th, 1980. Yeah, perfect.
So,
confirmed. Tell me what's going on with John Bishop.
So this is a 41-year-old chap who woke this morning at 8 o'clock with left-sided chest pain, feeling short of breath. He's got up for a wee and felt more short of breath, not feeling right. Wife was concerned and has phoned 999. On arrival, John is sat in bed. He does appear short of breath, however saturating at 100% on room air. I got him to do a quick walk around the upstairs of the property, and he does get more short of breath and his saturations do drop to 95. The chest pain that he's got, he's describing as sharp in nature, worse on inspiration. However, listening to his chest, it is nice and clear. He has good equal air entry. And I was just really wondering what your thoughts were.
Yeah, so just to repeat, so woke up this morning breathless, worsening on exertion, and you've noticed a change in his sats from rest to 100% down to 95,
yeah.
As he exerts himself. He's got some chest pain, but it sounds like you're not finding anything on examination, is that right?
No, so I've done a 12-lead ECG which I've sent across to you via EPR. There's no acute changes on there and it's sinus rhythm.
Yeah, I'll look that up in just a sec. Fantastic. And just tell me a bit more about his odds.
So his pulse rate is 90 and regular. His blood pressure is 142/84.
Yeah.
His resps are 20 at rest and they go up to 26, 27 on exertion.
Yeah.
I say I've given you his sats. His blood sugars were 6.4.
Yeah. And do you have a temperature there at all?
Yeah, so his temperature's 36.8, and I've also done a lateral flow test which was negative.
Oh, fantastic. And how uncomfortable is he at the moment?
So he's giving a pain score of 3 out of 10. He's already taken himself some paracetamol and he's been offered some codeine but has declined.
Okay, thanks. And is there any sense of what might have brought this on? Any immobility recently, or any physical activity?
No, so he's relatively well. He had his he's had his first vaccine. That was a few weeks ago. No issues. He is a lorry driver by trade, long distance, and quite often sleeps in the cab on overnight stays. He is a smoker. He does smoke 20 a day, but lives at home with his wife. That's his sort of social setup.
And any cardiac history or history of clots in the past?
No, nothing at all.
All right. You mentioned his wife. Is she at home with him at the moment?
She is. Yeah. He's yeah.
All right. So, from the sounds of it, it sounds like we ought to see him. It sounds like he's relatively stable. Things that are crossing my mind are causes for chest pain, including the possibility of PE.
Yeah.
So, definitely keen to assess him up at the hospital. What are you thinking? Are you going to convey him up, or do you think he's well enough to make his own way up?
So they're quite happy. We have had that discussion in the house, and they're more than happy to make their own way up because they have transport. I don't really think we're going to bring a lot to the party by bringing him up.
Right,
so I think
that's very reasonable. Will he be able to make his own way up fairly soon, though?
yeah. So wife's off today, so wife can bring him straight up, and she understands that obviously with visiting, she'll need to pick him up later.
Oh, fantastic. And I guess a key thing just to let them know is if things worsen, if he gets much worse, then he needs to just divert to ED. But I'm really happy for him to come straight up to the ambulatory assessment unit, which is on level 4 of the John Radcliffe Hospital. The sooner they get here, the better. And just let them know that it's going to be probably several hours, but they're expected to go home today.
Okay.
And during the course of their stay, he'll get blood tests. He's likely to get an X-ray. And possibly even a CT scan. I just can't guarantee when that's going to be. So let them know that that'll happen, and hopefully we're going to get them feeling better.
That's brilliant. Thanks very much, Doctor, and we'll get them to come straight up to you.
Brilliant. Thanks so much.
Thanks. Take care. Bye-bye.
Bye.
So I hope you enjoyed what you have just seen. For me, that was a great example of the clinical conversation between two colleagues, ensuring that the patient is at the centre of their care. So Jordan, if you were to just sum up with a couple of learning points, or what the take is from that, what would those two things be?
Well, I think you said it, Fiona, is that we're moving the patient back to the center of the clinical conversation. So what that case gave us an example of is how the patient's wishes and presentation influenced the decision that was made around them by two clinicians who were integrally involved in their care, both at the referring and at the receiving end. So the patient agenda, and in particular, that agenda to have their suffering addressed, but minimize its amount of time away from home and return back to the things that are important to them, is what SDEC's all about. And that should always be integral to the conversation. So what's the patient wanting? How are they involved in the decision around coming to hospital or the location of care if it's not hospital? So one, is that patient-centeredness. And then secondly is the credibility of the clinicians involved, holding the conversation where there is a shared purpose and a shared willingness to own some of the risk, to navigate the options available in the healthcare system, which they're familiar with and are empowered to be able to use, all with the intent that, again, what I've just said, the goal is minimize time away from home, ease suffering, resolve patient concern, and return them back to their fulfilling activities and what they wish to do.
Thank you very much.